Hello, I'm Matthew Weinstock, Senior Editor for Hospitals and Health Networks magazine. Welcome to H&HN Daily's videocast series. We're about to go through a surge in the need for primary care physicians. And what's behind that? Well, for starters, the nearly 30 million Americans who are going to gain insurance coverage under the Affordable Care Act. Another driver, the push for greater integration between providers and accountable care. But two critical questions remain. Will there be enough primary care physicians around? And will hospitals and health systems have strategies in place to nurture those clinicians? The American College of Physicians estimates that we could experience a 35,000 to 44,000 shortage of primary care doctors by 2025. I'm joined today by Dr. Martin Lipsky, Regional Dean at the University of Illinois Medical Center in Rockford, Illinois. We're going to talk about strategies that hospitals can put in place once they develop a primary care network. Dr. Lipsky, thanks for joining me.
Well, thanks for having me here. First, my own background is I'm a primary care physician. I am a family physician. And there's going to be an anticipated shortage of physicians in general, but particularly primary care. And so first, at the medical school level, we think we can begin to select students who are more likely to go into primary care.
And how do you identify those students?
Typically they're atypical students, or students sometimes are a little older. Sometimes they have less traditional backgrounds than a science degree. Frequently they come from smaller communities, particularly students who come from underserved communities. And also female physicians are more likely to go in primary care. I think hospitals spend too much time recruiting at the far end of the spectrum. What I'd like to see hospitals do in our case is nurture education, identify if it's a smaller community, identify students of promise and nurture and encourage them to go into healthcare.
So let's take a step back a little bit and broader then. Put in context for us the need for primary care physicians. We know about the potential shortage, but put it in context in terms of health reform and accountable care and integration.
Barbara Starfield, who's one of the pioneers of the concept of primary care, she estimates that if you have your own personal physician, you've reduced your mortality by 30%. That's a huge statistic. Or they can lower, a primary care physician can lower their death rate by 1 per 10,000. So in addition to cost effectiveness, it also improves health outcomes. One of the things that I think is new in medical schools is the concept of interprofessional education. And so we really strive to try to make sure our students learn side by side with pharmacists. We have our students work with nurse practitioners. We have our students work with occupational therapists and physical therapists. And our feeling is that physicians haven't always played well with others, and we think in healthcare in the future, it's going to be taken care of in teams, and we think of no better way to get started than with medical students. If you look at diabetes, by 2025, 25% of the adult population will have diabetes. There isn't enough endocrinologists to take care of all these people. So it's going to need to be a team of individuals. So it'll be a podiatrist that will help with the feed. It'll be a dietitian that will help instruct in diet. It'll be the family physician. It may be an endocrinologist helping add input and expertise into the team.
Right. And lastly, I want to ask you, because at the college, you do some work with rural hospitals as well. So what unique challenge do rural hospitals face when it comes to building a primary care network?
Boy, they have a huge problem. First, recruiting is really, really hard. And so one of the strategies our hospital has done is we preload this system. And so we have a rural medicine program. And to be part of that rural medicine program, you need to basically come from a rural community. In fact, we measure the rurality of a kid. And until I came to Rockford, I didn't even know rurality was a word. But we actually have a score where you get so many points if you grew up in a town of 1,000, if you lived on a farm, if you were in 4-H. And once we know a student can do the work, that they're academically qualified, then we look at these other factors. So then we've preloaded the system, and then we inoculate it by having these kids participate in special seminars. We have them do a project related to rural health. But then in their 4th year of medical school, they spend 16 weeks in a rural setting, frequently critical access hospital setting, and it's a combination not only learning about medicine, but immersion into the community. So you ask me what hospitals can do, and I think of how valuable our hospital partners are in that program. First of all, they commit the resources of both their physicians and staff to work with our students. They provide housing. Many members of the team donate their time to come into a selection committee meeting where we pick the right kids. They also identify kids that are in the community that they know that are interested in medicine, they think are good candidates, and they nurture them. Frequently, they'll make sure they meet with our recruiter. And so I think it's that whole pipeline. So this program's been around since 1992, and it takes about 7 years to see the pipeline. But each year we're putting 10 to 12 physicians now, who are largely primary care, in rural Illinois. And again, I think hospitals that are in cities should make the same type of investment in education. If you hire a recruiting firm, it's $25,000 to $50,000 per physician. And I think if you make this investment now, I think it'll pay off far better than a recruiting firm.
I appreciate your time today, Dr. Lipsky.
Okay, well, thank you for having me.
And for continuing coverage of physician issues, please check out HHNmag.com and look for other editions of H&HN Daily in your mailbox. Thanks.